neurology community of Argentina. I'm Oren Davinsky, a professor of neurology, neuroscience, psychiatry, and neurosurgery at the NYU School of Medicine, and I'm here to talk about cannabis, its pediatric epilepsy, and other indications. To begin with, I do have ownership in several companies related to the cannabis industry and have also consulted for other companies involved in pharmacologic treatment of epilepsy. I don't think any of these are directly relevant to my talk, although I will be mentioning some of the studies I've done for companies such as GW Pharmaceuticals. So I'm next going to turn to randomized controlled trials, and I think no one here in the audience needs to hear this, but I like to repeat it for myself, so excuse me. But RCTs are the best scientific evidence we have. They're blinded in that both the clinicians and the patients don't know what the individual who's the subject is receiving for a period of time. Patients are randomly assigned to either the experimental or treatment groups, and so there can't be some subconscious benefit that, oh, this person's having more seizures, I think they really need to go in the experimental group. And so in this case, it's really important to remove those potential implicit or unknown biases that we all have. And then finally, we think of RCTs as really important to identify possible effectiveness of an intervention, like a drug, but they're also really helpful to determine whether adverse events are related to study medication or not. For example, it may be that 25% of people on a study drug get nauseous and complain of stomach discomfort. But if the placebo group has 28% getting nauseous and complaining of stomach discomfort, then the conclusion is that the study drug did not cause those side effects, that was part of the experimental paradigm, the patient population, the conditions, but not necessarily the drug itself. So this is the first randomized trial of cannabidiol in the form of Epidiolex from GW Pharmaceuticals. This was a phase 3 study done in 2 to 18-year-old individuals with Dravet syndrome. The only dose of CBD that was used was 20 milligrams per kilogram. The mean age of the subjects was 10 years. The median baseline of the motor seizures, which were the countable seizures in the study, were 13 per month. And on the right of the slide, you see that about 39% median reduction of convulsive seizures in the treatment group, and about 13% in the placebo group, which was statistically significant with a p-value of less than 0.01. This slide also highlights an important take-home message that CBD is a drug. I know we like to think of things that come from natural plants as natural, and it is in that way, but when we take 100 pounds of plant material that has hundreds of compounds and extract one single molecule and purify it to 99%, that is called a drug. Similarly, and not to negatively taint CBD, but just by analogy, cocaine comes from a plant grown in the Andes, the coca plant. It's been used by humans there for probably millennia, and when the leaves are chewed, it does provide some stimulation, some appetite suppression, which individuals there have used it for millennia, as I said. But its safety and efficacy in inducing stimulation, for example, and side effects go up phenomenally when you take hundreds of pounds of those leaves and distill out a single alkaloid named cocaine. So CBD has side effects, and if you look at the serious adverse events, they occurred in 10 of the CBD patients and only 3 of the placebos. And with regards to discontinuation from the study due to side effects, that occurred 8 times in the CBD group and only 1 in the placebo group. And that strongly suggests that CBD really is a bioactive molecule that has both beneficial and side effects. These are the randomized studies done in Lennox-Gastaut. I'll cover the first one on the left. That was led by Elizabeth Thiel. She enrolled 171 patients across a number of centers. These included children and adults up to age 55, and they looked only at the 20 milligram per kilogram per day dose, and again found a very statistically significant median reduction in drop seizures that was far greater in the treatment than the placebo group. Myself and other colleagues did a separate study where we looked at 2 doses, 10 milligrams per kilogram per day and 20. And we found that there was a significant improvement in seizure reduction with CBD versus placebo. It was slightly greater, as you can see, in the higher dose, but as I'll get to, the side effects, not surprisingly, were also higher in the group that received twice the dose. And so many of us feel that 10 milligram per kilogram per day is probably a better target dose for CBD in Lennox-Gastaut and probably in Dravet syndrome as well. Keep in mind, we did not study 5 milligrams or 8 milligrams or 12 milligrams per kilogram per day, and that there's a lot of individual variability. So some patients may do much better on a higher dose, and some may do much better on a lower dose, as is, I think, true for almost everything we treat. Well, let's turn to the side effects that I had mentioned before. What were some of the ones that were higher among the CBD-treated group? They included somnolence or sedation, gastrointestinal problems like decreased appetite and diarrhea, elevation of the hepatic enzymes, the transaminases, a higher rate of infections, especially pneumonia, and drug interactions, which we'll touch on, mainly because CBD inhibits the liver enzyme CYP, or cytochrome 2C19. As I said, the withdrawals were greater in the CBD group across all of the randomized studies, and those were mainly due to elevated liver enzymes and somnolence. So what are some of the drugs that affect CBD metabolism? So again, not where CBD interferes with other drugs, but drugs that interfere with CBD. And the main groups are these 3A4 inducers like carbamazepine and phenytoin. They will actually reduce levels of CBD. And the drugs like ketoconazole that inhibit that liver enzyme will lead to increased levels of CBD. I should mention, and I think it may be in a coming slide, but that the levels of the metabolite of clobazam nordesmethyl metabolite, can go up 4 to 5-fold when individuals on clobazam have cannabidiol added to it. So keep in mind that N-desmethyl metabolite can lead to sedation, may also lead to improved seizure control, and needs to be something you consider on patients who take clobazam to whom CBD is added, or vice versa, they're on CBD and clobazam is added. I want to turn now to another study, and this was done by Blythe McCoy when she was at Sick Kids Hospital in Toronto. This was an open-label study of a 100 to 2 or 50 to 1 ratio higher in CBD than THC, made by Tilray, which I no longer have an affiliation with, but I did in the past. And there were 19 subjects, all, again, pediatric, 20-week study period. The median dose was about 13.3 milligrams per kilogram per day of CBD, and those subjects had a little under 0.3 milligrams per kilogram per day of THC. Side effects were similar: somnolence, decreased appetite, diarrhea, some elevation of liver functions, and decreased platelets, especially in patients who are also taking valproic acid. One of the things you see on the slide below is that the number of subjects who had somnolence progressively decreased over time, suggesting that this is a side effect to which tolerance develops. And this slide here looks at the efficacy in that study by Dr. McCoy, and reductions in median motor seizure frequency were about 71%, and the 50% responder rate was 63%, so that means 63% of the subjects had a 50% or greater reduction in motor seizures during treatment with the study medication. There was also a statistically significant improvement in quality of life compared to pretreatment baseline. Again, remember, this is an open-label study. We don't have a placebo arm here. And there was also a reduction in the frequency of spike activity on the EEG. And I do believe Tilray may have products in Argentina, but I will not sure of that. So I'll leave it to you to decide. I want to turn to another topic, which for me has been one of the fascinating side stories of my interest in cannabidiol, and that is the entourage effect. Now, Raphael Mechoulam is the Israeli scientist at Hebrew University who first isolated CBD and THC, who first synthesized them, and first studied them and learned about the CB1 receptors, and did a lot of the initial work, including even an early epilepsy trial several decades ago. But this is a study where he and his colleagues found that there's a a naturally occurring lipid in your brain, in my brain hopefully, called 2-AG. It's a short for a long name, which I won't bore you with. But 2-AG is a stimulant of the CB1 receptor, just like THC. So again, we have CB1 receptors not because evolution and biology was hoping we'd discover the cannabis plant. We have CB1 receptors in our brain because we have lipids that stimulate those receptors and have a function, and that's why they're there. It turns out there are several esters of 2-AG that are also present in our brain, but they alone do not bind to the CB1 receptor. However, in the presence of 2-AG, these esters increase the effectiveness of 2-AG on stimulating CB1 receptors. So again, these esters don't do anything to the CB1 receptor on their own, but in the presence of 2-AG, they will strongly stimulate these receptors. And this was referred to by Ben Shapat, who's the first author, and Meshulam as the entourage effect. I think it's a perfectly nice name. We all understand that as a group or in combination, they have synergy, but alone the esters of 2-AG don't do anything. Unfortunately, this entourage effect, which was nicely described in a very specific set of studies, has been broadly applied across CBD and THC and even wider. So CBD and THC, and I'll update this slide in a second, they may act synergistically, but when I made this slide a few years ago, despite everyone hyping this synergy, there really was no experimental data in cell cultures, in animals, or in humans, other than some anecdotal people saying it works better when I take them both together, but that was completely uncontrolled. And I'll take a step back. I personally love evolution. I believe Dobzhansky's quote is one of the most important ones for us to think about in medicine, that nothing in biology makes sense except in light of evolution. So why do cannabis plants have up to 500 different cannabinoids, terpenes, and flavonoids? Well, they do it for the plant's survival and reproduction. They don't do it to treat epilepsy or anxiety or other human disorders. The plants evolved to make chemicals like CBD or THC, takes resources, takes enzymes, takes energy, and they only do it if they need to do it. If they're in an environment that those things aren't needed, they ramp down production of those different compounds. And so these compounds are there to prevent desiccation, to prevent insects or bacteria or mold or fungus from growing on them. They are not there for human medicine. As a beneficial side benefit, yes, some of these compounds in plants are quite helpful in treating human disease. And I'll finish this slide with a quote just from a non-reputable website, yourbrainonbliss.com. New research confirms what has long been thought: CBD, in addition to other entourage cannabinoids like THC, is far superior medically to pure CBD. Now, this is just, think about this sentence, how broad it is. It doesn't even say superior medically for what. At the time this was written, I don't think there was even, like I said, data from a petri dish, never mind human medical studies. Since I started, this slide actually refers to a study that was published in Epilepsia earlier this year, within the last 3 months, and it does show that the entourage effect does have some support in amygdala kindling. So this is a model of epilepsy, focal epilepsy, and these animals that are kindled do develop focal impaired awareness seizures, formerly called complex partial seizures, and both CBD and THC have anti-seizure properties in this kindling model. THC suppresses amygdala focus at doses that cause decreased locomotion, and adding a small amount of THC to CBD improves the efficacy of CBD. So this actually is an example where this combination does have a synergistic, or if you'd like, entourage effect. And the authors postulate that the combination might be effective in treating focal impaired awareness seizures. There's no real human data to support this, other than perhaps a study in tuberous sclerosis complex, but it's intriguing and certainly worthy of more follow-up and more controlled investigations in both animals and humans. Well, let's now turn to some of the other studies that have been done in the epilepsies. The first one here is one that was done by Zynerba and recently published. It looked at 182 patients treated with CBD administered via a transdermal route. This was a synthetic CBD, so they either got placebo or CBD. It was an open label study, and in the past, higher doses had been promising, but there were no placebos. In the study that did use placebos, there was no differentiation between the active treatment and the placebo group. So this was a negative study of CBD in focal epilepsy. Another study done by GW Pharma that I was not involved in was used CBDV, which is very similar to CBD in its receptor properties, and enrolled 152 patients. And again, there was no differentiation in the study between the placebo and the active treatment arm, suggesting that CBD and CBDV are likely not to be effective in focal epilepsy, although I don't think we have quite enough evidence to make any definitive statement. And these positive studies, which I didn't review here, but in tuberous sclerosis complex, Elizabeth Thiel led a study using very high doses, 25 or 50 milligrams per kilograms per day in tuberous sclerosis patients, and found significant reductions in seizure frequencies. And since tuberous sclerosis patients have primarily focal seizures, that is one set of evidence that supports these compounds may be helpful in focal epilepsy, but more data is needed because these two studies were both negative. I'm going to turn now to a very different disorder from epilepsy, but one seen commonly by pediatric neurologists and also, of course, by adult neurologists, and that's autism. So this was one of the first studies that looked at 20 patients with a transdermal synthetic CBD. It was open label, so again, no placebo group, and they assessed anxiety and behavior and found a statistically significant greater reduction than would be expected by placebo. But again, I should say there's no placebo in the study. They used the Adams scale and looked at anxiety and mood changes, and they also looked at a Fragile X score, because most of these patients, or all of them, I believe, in the study had Fragile X, and also found benefits here. There were side effects in a fairly significant number of patients, but they were almost all mild and none were serious, and they paralleled the ones that were previously reported, although UTI in 10% is unusual, and I'm not sure whether that was just background noise in this population or truly a potential side effect of this therapy. There have been several other studies that have been published. This was, I believe, from a group in Israel, 53 patients, mainly children and young adults, CBD together with THC in a 1 to 20, 20 parts CBD it should be to 1 part THC, and they were treated for 1 month to almost a year and a half or so. And as you can see, many of the worrisome behaviors in individuals with autism, self-injury, hyperactivity, sleep problems, and anxiety all improved, although anxiety less so, and there was some worsening, and one wonders if that might have been from THC, which can produce anxiety and cause sleep problems in some people. So again, more data is needed and from randomized study. Side effects were there, and again, were similar to the ones we've previously discussed. This is another study of 60 patients, again, I believe from Israel, with a CBD-enriched cannabis, and about 60% or more were much improved. Adverse effects included sleep disturbance, irritability, decreased appetite, and even psychosis, I believe, which was in a single patient. Another study from Israel, reported in Science Reports 2 years ago, looked at 188 patients with autism treated with a 20-part CBD to 1 part THC formulation, and 6 months into the study, 82% were still in the active study, and 60% were available for assessment. And there were improvements that were significant in 30%, moderate in 54%, and then slight or no change in the remainder. And side effects included restlessness, tiredness, some high feeling, hunger, and dry mouth. So again, relatively well tolerated, and certainly in autism signs that this may well be a beneficial treatment. I myself would love to see pure CBD. I think before you go mixing compounds, it is nice to see one compound on its own, so we don't give people more medications than they need to. But again, we have to work with the data we have. There are several studies in autism that are now ongoing, one using cannabidiol at the NYU Child Study Center, led by my colleague Javier Castellanos, and one using CBDV, by Eric Hollander and myself across both the Montefiore and NYU medical centers. Both of these are ongoing, and no results are available at this time. I'm going to turn now to another disorder, anxiety, for which there's evidence from both animals and humans that CBD may be an effective therapy. Keep in mind, many of the anxiolytics that we have work, especially buspirone, by stimulating the serotonin 1A receptor, and CBD does this as well. Benzodiazepines, which work predominantly on the GABA receptor, and SSRIs and SNRIs, which work on the serotonin and norepinephrine receptors, are also valuable treatments for anxiety disorders. I personally don't ever like to use benzodiazepines except in very short-term treatments or as very intermittent treatments, giving 5 to a patient to be used over a month or longer. The problem with benzodiazepines is, just like opiates, they're among the most receptive medications and the receptors in our body that lead to addiction and potentially can be part of lethal overdoses. In America, the use of benzodiazepines has skyrocketed from 28 million prescriptions in 2003 to a more than doubling 12 years later. And overdose deaths went from about 0.6 in 1996 to more than 5-fold greater over 3 in 2010. So a 6-fold increase or so, or 5-fold increase over a 14-year period. And again, many of the opiate overdose deaths in the United States, at least I know these, are also associated with concomitant benzodiazepine use. So again, it's really, we should as a medical community use these drugs very, very sparingly. I personally only use clobazam for long-term treatment in epilepsy. So could CBD reduction in anxiety be related to the 5-HT1A receptor? It's quite possible. We know that there are some preclinical studies, such as a chronic stress model, and this is one that was published a while ago. And you can look at the open ARMS, which is looking at vehicle versus CBD in a stressed versus non-stressed state. And with vehicle, you can see that the animals are, quite less willing to be in an open area when they're stressed, whereas when CBD is given, they're actually much more willing to be in the open. So again, speaks to the fact that CBD can have anti-anxiety properties in rodent models. And this is another study looking at public speaking using a 600 milligram dose of CBD in volunteers. And again, the placebo here is red, so this is a fair amount of anxiety. The CBD is in blue, and then the healthy group that does not have social anxiety disorder is the black on the bottom. So again, CBD reduced the anxiety as compared with placebo, although not to the level of healthy adults who do not have social anxiety disorder. And again, the placebo, interestingly, produced greater sedation, or I should say produced the least CBD intermediate. So again, there is evidence for efficacy of CBD in anxiety. This is not solid, hard proof, but it's certainly suggestive and certainly goes along with the preclinical models. Well, I want to finish. I'm not familiar with the cannabis marketing in Argentina, but I am talking here about the United States, and I consider the United States still to be the Wild West with regards to the use of cannabis products in medical dispensaries, which is a state-administered program. And the challenges are, and I like to distinguish religion from science. I have nothing against religion. I think people should be allowed to believe in whatever God or even multiple gods they choose to believe in, but that's not what science is about. So religion is belief without evidence. If your religious leader tells you something and you believe it, you are perfectly have every right to believe it. But I would argue that when you do so, you do it without asking for scientific proof. You do it because you believe in a prophet, you believe in holy scriptures that have been passed down in your religion. But science is completely different. Science is digging hard, finding evidence, pushing to get better evidence, and almost no matter how good the evidence, we always keep doubt as a scientist. So even when you're almost certain, you have to have some doubt. If people say, is the COVID vaccine good to take? I would say absolutely yes, because the preponderance of evidence is remarkably strong that the benefit outweighs the risk. The chance of dying in the United States, if you go on the CDC website, from COVID is about 1 in 80. The chance of dying from the vaccine, there's been about 360 million doses given out. Probably less than 10 deaths are clearly related to the vaccine, although there have been probably 6,000 or 7,000 deaths reported. Clearly, some people are 85 and going to get a vaccine and going to die from a heart attack 2 days later, but no one would think that is really related to the vaccine per se. So I think the preponderance of evidence in some places is never 100%, as is true for the vaccine, but it can be very strong using scientific data. So what are the issues with medical cannabis in the general dispensaries that worry me? Well, there needs to be a consistent formulation and quality, and many of the states mandate this, and that's fantastic. I am a prescriber in New York and New Jersey, where I think there are good procedures in place to monitor. But there's still issues. Dispensary staff may strongly influence patients' choice of product and dose, and these may be people with high school educations who may have very little scientific or medical understanding, or may even be incentivized to sell certain products. I don't know, but I don't think that's the way medications should be recommended. You wouldn't go to a pharmacy and have a high school graduate telling someone with hypertension or asthma which medication to use. Professionals and lay individuals believe they have answers, and again, this parallels what's happened with the supplement industry back several decades ago. The FDA tried to rein in the supplement industry, asking them if they're going to say they have a product that improves memory. That's fine. Just show us the data. Show that you've done a good randomized placebo-controlled trial that established that your product improves memory. And then you'll get that indication. You could put it all over your label. The supplement industry raised a lot of money, used scare tactics, tried to convince Americans that their independence was going to be taken away, that the FDA was going to steal their vitamins. And so they lobbied, mainly the supplement industry, and relaxed the laws, and the amount of supplements sold in the United States has probably gone up 5 to 10-fold since that legislation was passed. It was actually started to rein in the industry, but the industry won, as it usually does, just like in the food. Why sodas can be sold in high schools that get paid millions of dollars to put the vending machines in against the better health of the students. So we need to be aware here, too, of the law of unintended consequences. Many times in medicine, and I would argue many more times in politics, people do things that they think they're doing for good reasons, but they end up doing more harm. So one of my favorite examples is what happened with the cholesterol and saturated fat debates, which began in the 1950s. Many studies showed that individuals in communities like Framingham, Massachusetts, in areas like Puerto Rico, Hawaii, there was no relationship between the amount of saturated fat individuals ate and cholesterol levels. There was no relationship between the amount of saturated animal fat people ate and heart disease or total mortality. But leaders in government had already accepted that fats were bad for health. They also thought saturated fats cause cancer, something that's been definitively disproven in many, many large prospective observational studies and also randomized controlled trials. But the idea that saturated fats are evil still is with us. But the worst part is when we convicted the wrong criminal, in this case I believe saturated fats, not that they're completely benign, but I think most of the harm laid on their doorstep has been falsely accused. But the real criminals here